When it comes to idiopathic inflammatory myopathies, or IIMs, we're in the middle of a major shift. We're moving away from these broad, kind of vague labels and getting much more specific, zeroing in on the underlying causes, which of course gives us much clearer therapeutic targets. So let's break down what this really means for your day-to-day practice.
All right, let's dive right in by challenging a diagnosis we've all used for years: polymyositis. The thing is, we now know that a lot of what we used to call polymyositis are actually totally distinct diseases, like immune-mediated necrotizing myopathy or antisynthetase syndrome. And making that distinction, well, it's not just academic. It completely changes your patient's prognosis and how you're going to treat them.
So here's our game plan. We'll walk through the new classification system, break down the 4 key clinical pictures you'll see, go over the modern diagnostic toolkit, talk about navigating mimics and malignancy, and then tie it all together with serology-guided treatment.
Okay, first up, let's talk about this fundamental shift. We're really moving away from just describing what we see, the phenotype, and digging deeper into the why, the underlying etiology.
You know, the traditional buckets we used to use just aren't cutting it anymore. They lump together diseases that are fundamentally different. Think about it. A patient with antisynthetase syndrome has a totally different clinical journey and set of risks compared to someone with necrotizing myopathy. Our diagnostic framework has to catch up to that reality.
So this is the new model. It's much more comprehensive, organizing IMS into 4 main subtypes: dermatomyositis, inclusion body myopathy, immune-mediated necrotizing myopathy, and overlap myopathy, which is where antisynthetase syndrome fits in. And the foundation for all of this? It's about integrating everything: the clinical features, the serology, and the myopathology. You need all 3 for a complete picture.
All right, let's get practical and look at these 4 key phenotypes and the high-yield distinctions that really matter in the clinic.
Think of this table as your clinical roadmap. The syndrome you see in front of you points directly to a specific antibody you should order and a pathology pattern to look for. For example, you see that classic skin rash? You're thinking dermatomyositis, so you're going to look for antibodies like anti-TIF1 gamma, and you'd expect to see MXA expression on the biopsy. Or what about asymmetric finger flexor weakness? That should make you think of IBM and its partner, the anti-NT5C1A antibody. This is what precision medicine actually looks like in practice.
Okay, let's open up the diagnostic toolkit. In this new world, the MVPs, the real central players, are the myositis-specific autoantibodies, or MSAs. They are absolutely essential to any modern workup.
And here's the crucial point. MSAs are so much more than just diagnostic labels. They're incredibly powerful prognostic and predictive tools. A single antibody result can tell you about a patient's risk for interstitial lung disease, their odds of having a hidden cancer, and even give you clues about how they'll respond to different therapies. It's a real game changer.
Let's look at a really powerful example of how serology changes everything you do. We'll focus on just one of these antibodies, anti-TIF1 gamma.
So get this. In your dermatomyositis patients who are over 40 and test positive for anti-TIF1 gamma, their associated risk for an underlying malignancy can be as high as 75%. That is a staggering number you absolutely cannot afford to miss.
So, what does this mean? It means this one blood test result completely reroutes your management plan. It's no longer optional. It mandates an aggressive, thorough malignancy screening. And finding that cancer early? That can be life-saving.
This comparison is so important because it shows that even within one subtype, like IMNM, the specific autoantibody tells a different story. Anti-HMGCR myopathy is the one we all link with statins, even though plenty of patients are statin naive, while anti-SRP has no link to statins and often hits much harder, with severe rapid weakness and even cardiac involvement. You're really dealing with 2 different diseases here, and they require different levels of clinical vigilance.
So here's what a modern diagnostic pathway should look like. Once you have that initial clinical suspicion, the key is to order a comprehensive myositis antibody panel early on. Seriously, don't wait. The results of that panel then become your pivot point, helping you narrow your differential and decide strategically whether you even need an EMG, an MRI, or a biopsy. It's all about getting to a precise clinical seropathologic diagnosis much more efficiently.
All right, let's tackle 2 of the biggest challenges in any myopathy workup: that ever-present risk of an associated cancer and the tricky business of telling IIMs apart from their many mimics. As we've seen, cancer risk isn't a blanket concern across all IIMs. It's highly stratified by the autoantibody profile.
Anti-TIF1 gamma, as we mentioned, carries a massive odds ratio of 27 for malignancy. Anti-NXP2 is also a major red flag. But then, what's fascinating is that some antibodies, like anti-Jo1, might actually be protective. So you can see why serology is just critical for risk stratification.
Now, when you see any of these features, you have to hit the brakes and think, could this be something else? I'm talking about things like asymmetric weakness, a super slow progression over years instead of months, or, and this is a big one, a lack of response to immunosuppression. These are major red flags. Why? Because many genetic myopathies can actually have inflammation on biopsy and masquerade as an IIM. And if you treat them with immunosuppressants, you're just causing harm with zero benefit.
And finally, let's connect all this precise diagnostic work directly to treatment. Because, let's be honest, that's the ultimate goal, right? This new framework lets us really start to individualize therapy.
This is such a critical point. If a patient isn't responding to what should be appropriate therapy, your first thought shouldn't be to just escalate immunosuppression endlessly. It should be to go back and reevaluate the diagnosis. With the big exception of sporadic IBM, if your patient isn't getting better, you've got to ask yourself, do I have the right diagnosis?
And this just spells it out so clearly. A specific diagnosis directly informs your treatment choice. If you have a patient with anti-HMGCR positive IMNM, you know IVIG can be highly effective. For anti-synthetase syndrome with ILD, you know to avoid methotrexate because of the pulmonary risk. And for sporadic IBM, you know that conventional immunosuppressants are pretty much useless, which spares the patient all those unnecessary side effects.
Look, the goal of this entire approach is to move beyond generic, unhelpful labels like polymyositis. It's about using the modern tools we have, especially serology, to get to a precise clinico-seropathologic diagnosis. Because that precision is what allows for accurate prognostication and, most importantly, leads to better, safer, and truly personalized care for our patients.